I welcome you all. So happy to see you all on a spot in a sleep program. When so much of everybody is talking about interventional pulmonology, at least some of you have gathered here to learn about sleep. And when Dr. Guru was talking, I'm wondering, sir, whether you have secretly done a fellowship in sleep medicine also. So one thing I would like to tell is this field is a relatively new field, and the ramifications that these sleep problems have on our various systems in the body and the challenges they face to various specialties are just being understood. So in this context, I would like to present 5 case stories of my patients. I'm not going to do a very typical case presentation, but I would like to highlight few points these patients silently conveyed to me through their presentation. And whatever understanding I had of sleep medicine is because of the great person sitting here, Dr. Suri sir. He so beautifully explains the pathophysiology and makes us understand and apply it in clinical practice. Thank you for that, sir, for showing us a new direction. And I will just do the presentation a different way to break the monotony, and I hope you enjoy this. So this is the story of a 36-year-old male patient, resident of USA, recently gained about 10 kg, recently had a divorce. He feels he has no problem with his sleep, and there were no daytime symptoms. He denies any problem with his sleep or daily activities. He has no comorbidities, and he is happy with himself. However, his wife, second wife, he recently got married, when he came to us, says that her sleep was getting disturbed. She had pauses in breathing, and so she feels that something is not right. And she also noticed him going to washrooms, couple of happy with it. This iconic movie, which was made about 44 years ago. So there, Sanjeev Kumar and Vidya Sinha, marital secretary in their lives. Though I might sound misogynistic, that was how the story goes. So here, our woe is the sleep problem. It is just not a laughing matter, but in marital life, sleep or snoring problems play a big havoc. And as per the US divorce statistics, snoring and sleep problems are the 3rd leading cause of divorces. It's not because of the sound that disturbs the sleep partner. It is because of the disturbance of the emotional, mental, and cognitive health, and a feeling of resentment and conflict, which leads to marital disharmony. So this is in fact a truth. And so let's see how the story goes. Now the patient feels, why should I consult when I am feeling all right? Why do I need a sleep study? And what should the physician do at that point? How do they convince the person that yes, you might have a problem and you need evaluation? Let us just look at some statistics. So this is the famous Wisconsin sleep cohort study. So what they did was, in the Wisconsin state employees, they wanted to see the prevalence of sleep apnea in the general population, and they followed them up longitudinally for many years. Now if you see here, from 1980 to 1994, 2% of women and 4% of men had sleep apnea, whereas when they did the calculations and estimations in 2007 to 10, you can see the proportional increase, lot of increase in the prevalence of obstructive sleep apnea. And this study is still going on to see the consequences of sleep apnea. Now this is an interesting study which looked at from various review articles the prevalence of obstructive sleep apnea in 2020. 1 billion sleep disordered breathing, that is 1/7 of the world population has obstructive sleep apnea. 425 million have clinically very significant obstructive sleep apnea. Most interestingly, India stands second, 29 million diagnosed cases estimated. The risk is highest in Asians, and we also fall in that. Why is it so? So here you can see again, over the period of years, how obstructive sleep apnea is increasing in males and females. The most important reason, we all know the obesity pandemic. All of us, many of us still try to control our weight, so it's not easy. So definitely that is contributing. And the aging population, definitely. Then the third important factor is craniofacial restriction. That means the way our soft tissues and bones are formed are different as compared to Caucasians and whites, and it has clearly been proven that this craniofacial restriction, for the same amount of obesity or lesser obesity, the sleep apnea will be higher in Asian population because of various factors like a large tongue or a large increased soft tissue or a shorter cranial base or a wider thyromental angle. When all these factors are there, the person might not be obese, but we Asians are more prone for sleep apnea because of this problem. And the worst combination is a craniofacial restriction plus obesity together. Then you can imagine what we are going through. So this is again the first study which looked at clustering of obstructive sleep apnea. Here I want to drive one point is that they looked at polysomnography, they gave some questionnaires, and then they did a psychomotor vigilance test to see the daytime activeness. And they found that 15 to 20% of obstructive sleep apnea patients will not have any symptoms. They did not have any symptoms, and their questionnaires are all normal. Right? But what happened to these patients? Do they develop diseases later on? The mortality risk increases as compared to normal population. All-cause mortality is 3.8, odds ratio 5.2 is the cardiovascular mortality. So definitely there is an increased survival. So these patients, what I want to drive here is this particular person who has snoring and disturbed sleep, who has gained weight, who had a marital disharmony, we cannot ignore. We need to see whether this patient has obstructive sleep apnea or not, and they don't come and say I have snoring or I have sleep apnea. They might go to different specialties with the hypertension or increased pain sensitivity or irritability or losing promotions at job, these sort of things. So what are the factors here which were important? Spouse was disturbed. Dr. Shailaja, I can see here, she was the one who referred the patient to me, my good friend. So aunt was a pulmonologist, and she suspected that something could be wrong in this patient, and she wanted a level 1 sleep study, and she sent the patient to me. Yes, we did a stop bang. This is the screening questionnaire for diagnosing, and stop bang was 5, which suggested that yes, there could be a high probability of significant sleep apnea. Interestingly, the Epworth sleepiness score was only 4. So if we go just by daytime sleepiness evaluation, we might say he doesn't have anything. Why does he need a sleep study? So we did a level 1 sleep study. We wanted to convince the patient and show him whether he has any significant burden of disease. Now, see, in the sleep study, we want to look at the overall view of what is happening, the bird's eye shot, that is called a hypnogram. Okay? Here you can see beautifully the stages of sleep, the REM sleep. You can see so many desaturations happening, particularly during REM sleep. You can see heart rate fluctuations. These are all the apneas. See how dense they are. The whole night what has happened, if you want to see, we look at the hypnogram. Lot of apneas happening, lot of obstructive apneas happening. These are the arousal, sorry. These are the obstructive apneas. Mixed apneas are present, hypoapneas are present. So many events happening in this patient silently, and he doesn't have any symptoms in the daytime. See, look at this thing. The AHI index, which should be less than 5 normally, and more than 30 is severe. The AHI index is 108, unbelievably high. So this is what obstructive apnea is, where airflow is absent. There is good effort from the ribcage and abdomen. In central apnea, all the 3 will be absent. So this patient had mixed apneas. That means in the initial part, there is no effort along with the absent airflow. In the second part, the effort starts. Maybe this patient has some amount of ventilatory instability also. So we can see here clearly the mixed apneas happening. So there is a lot of burden of events, respiratory events happening during sleep in this patient. So the patient feels that he is okay, but wife is suffering here, and the OA is playing a big role in their night life. It is, believe me, it is very, very difficult if a spouse has a sleeping problem or snoring or anything. It is very difficult. Both of them gets disturbed, and their emotional balance gets disturbed in the daytime. So the patient is thinking all is well, but unfortunately, if a patient has daytime sleepiness or some disturbance in the daytime, then they feel much better after treatment. How to convince a patient who feels nothing is wrong and who doesn't have any symptoms? It's very difficult. So he doesn't realize what is going to happen in the future, what is there happening silently in his body. Okay? So what are the key features here? Young patient, BMI high, definitely 32. No symptoms, Epworth sleepiness score less than 10, not significant. Notice snoring and witness apnea, some nocturia was there. Very high apnea hyper index, very high RERAS. RERAS means this because of the increased respiratory effort, the airflow is getting narrowed. So long apneas, maximum was about 56 seconds. High desaturation index, we want to see how much time the saturation level is less than 90% or how low is the saturation. All those were very high for this patient. So is it not our responsibility to convince these patients, because otherwise, okay, no symptoms, you don't do a sleep study, what is going to happen to this patient in the future? They are going to land up in severe cardiovascular risks. So it is our responsibility to convince the patient that if you leave it, it is a big risk and take it forward. So as Dr. Paramjyoti sir was telling, now cardiology societies have added sleep to their essential 7, and now 8th essential factor for good health is sleep. So what are the risk factors for a cardiovascular risk in an obstructive sleep apnea patient? Any younger patient, excessive daytime sleepiness. Our patient does not have. High hypoxic burden, yes, it is there. Nocturnal heart rate changes, yes. Total sleep time less than 90%, it was almost 215 minutes. Sleep arousal burden was high. Duration of obstructive events were long. So this patient definitely was at a high risk for cardiovascular things in the future. So if the directors and producers of a movie like Toilet can make a movie and then sell it, why can't we sell this concept of obstructive sleep apnea prevalence and importance to our patients? We can definitely do this. So once the treatment is started, then everything is fine, patient is happy. I'm sure Dr. Shelja will watch for good satisfaction. So, oh, excellent. That's excellent. So that's how important sleep apnea is. Patient not presenting with symptoms or having so much of burden and having daytime mental disturbances and marital conflicts. That's our story, first story. The second story is of an elderly woman with refractory hypertension. So anybody who's more than 2 drugs or so is called jiddi hypertension. So this lady was on 4 different groups of drugs. She came to our ICU with accelerated hypertension. Our ICU team detected, our ICU head, in fact, Dr. Ramesh called me and he said, Madam, I think that something is going wrong, lot of snoring. Not only that, I'm seeing lot of fluctuations in blood pressure in the night time. This patient also denied any sleep problems. Typically, all the sleep patients will say we don't have any problem with their sleep. We have to take the history from the bed partners. BMI was high, blood pressure was high, neck circumference was high, there was mild pedal edema and retrognathia with left ventricular hypertension. See, if you draw a line from here to here, you can see the chin, how back it is. This patient typically has a micrognathia and a retrognathia. Again, high burden of hypoxic thing, less than 90%, 89 minutes, 211 minutes. So we can see here, this is again Dr. Suri's slide. See, normally in the daytime we have an active sympathetic system and vagal system takes over in the night time. That is why we have about 10% of blood pressure drop in the night time. Now you can see here in obstructive sleep apnea patients, there is not much fall in systolic. See, this is in the control, this is systolic, this is night period, this is day period. Interestingly, along with the diastolic lesser drop, there is also higher diastolic pressure in the daytime in obstructive sleep apnea patients. So this is what is called nocturnal non-dippers. This is very dangerous. Even driving, if they don't dip in the night time, what happens? This can lead to, visual problems to the person who is driving opposite and lead to accidents. The same happens if there is a nocturnal non-dipping blood pressure. This can lead to a lot of problems like how our patient landed up. So all these comorbidities are associated, cardiac comorbidities and hypertension are associated with our obstructive sleep apnea patients. Let me not go into it, but obstructive sleep apnea has an effect on the left ventricular transmural pressure through various mechanisms, and this increased left ventricular transmural pressure first leads to diastolic dysfunction and later on to heart failures. So that's very important. So key features: refractory hypertension requiring ICU admission, nocturnal desaturations, nocturnal rise in blood pressure, nocturnal BP fluctuations, associated LV dysfunction. Neither family nor her a patient nor their initial doctors were aware that sleep apnea is the one which is causing all these problems and making the patient take 4 different classes of antihypertensives. Now the sleep study, see, it will be something like this. This is a split night study. See, you see this line here? This is the diagnostic part, this is the titration part. These are all the indices. So much of desaturation and apnea is happening in the first part and a lot of snoring. Now what happened after we started CPAP? This patient, fortunately, with a simple CPAP, we could abolish most of the desaturations. There is one desaturation here. Most of the apneas are abolished, snoring is abolished. So in a level 1 sleep app, particularly cardiac patients, doing a level 1 sleep study is very important because we see the events and then gradually we increase the pressures and in front of our own eyes we abolish the things. So as somebody said here, all the reason for the cardiac decompensations or cardiac problems are our obstructive sleep apnea or upper airway. The heart will be crying, but we don't realize that this is the root cause. So that's very, very important to know. Any decompensated disease, sleep is the common denominator, and we need to see whether we need to ask sleep history for all the patients and see whether this is the contributing factor. The more severe the disease, the more resistant to hypertension, particularly when there is no remodeling. And when along with antihypertensives, the response to CPAP is very good. And the disease risk, you can see here that the disease risk reduces significantly with treatment. So we need to protect our heart by taking care of our upper airway, by taking care of our snoring. Right. So see, unfortunately, very talented people who died in their sleep because of sudden cardiac deaths because of obstructive sleep apnea, very severe obstructive sleep apnea. This has to be avoided. That is the idea. Younger people, productive group, India needs our younger people and for their productivity. And if our younger people are suffering with this, then this is not acceptable as a medical fraternity. We need to do something. The third patient is the story of a patient who underwent a total knee replacement. 56-year-old female, hypertensive, again obese, underwent TKR, pulmonology referral on day 4. So when I went, patient, yes, so very obese patient, drowsy, SpO2 was 97% on 3 liters. When I removed the oxygen, it was 85. Chest X-ray was normal. We ruled out fluid overload. We ruled out pulmonary embolism. We can see that this patient is having a type 2 respiratory failure. Now what are the next steps? So if the Natu Natu song has got the Oscar, it's not without any reason. It is because of a very good synchronization between the director, music director, and all these people. So similar way, if you want a patient to come out very nicely without any complications, pre-op evaluation is important. Okay, sometimes we might not be able to catch them pre-op, but post-op we need to do in a proper way so that this patient sails out of our hospital very smoothly. So what did I do? Immediately I reduced the oxygen, started on NIV, removed. Then I said, when I asked my registrar, is there anything? No, madam, nothing is there. I said, no, look for any sedatives. Then they said, yes, fentanyl patch is there. Then slowly they said, yes, Restil tablet is also there for this patient. So we stopped all those things, and then without much effort, this patient became all right. And later on, we planned a level 1 sleep study for this patient. So what are the learning points? Why did this patient land up in such a situation? That's because whenever a high BMI patient or morbid obesity patient goes for a surgery, we need to have a high index of suspicion. We need to utilize stop bank questionnaire. A beautiful screening questionnaire has been developed. So we need to utilize this questionnaire for evaluating the probability of significant sleep apnea. If these patients already have sleep apnea, they have to use CPAP before surgery. We have to minimize the opioid use and avoid benzodiazepines. Continuous oxygen monitoring when required, blood gas monitoring is important. Empiric CPAP or NIV when we suspect a type 2 failure due to obesity hypoventilation syndrome. Most important thing is controlled oxygen. Just go on giving 3 liters, 5 liters oxygen. So we just want a 92 saturation for these patients, that's all. So we have to give controlled oxygen or no oxygen. So this is the same thing here. I just want to stress one point here, that is, okay, this we already discussed, stop bank. Post-operative, what care we already discussed. Here, intraoperatively, most important for the anesthetist is to extubate the patient only after the patient is fully awake. Otherwise, early extubation and the patient is still drowsy, the patient will get into type 2 failure. If they are not monitored, they can even die. All right. Another important point here is, after surgery, patients will have lesser sleep in the night time. So their REM sleep will be lesser. So on third or fourth day, there will be a REM rebound, and that is the time when most of the events happen. So we get a referrals on third day or so, and there is the most dangerous period. So we need to watch out for that. So the next stories of a woman who is not happy with her treatment options. If you look at this sleep study, AHI, that is the events, number of apneas or hyperapneas, are not much, 17.3, comes under moderate sleep apnea. But what is important to look at is what are the events occurring in supine position, in non-supine position. So in supine position, there are 23. In non-supine, only 4. So here the sleep study is trying to tell us something very important. So this is how it is, the events happening in supine position. This is the supine. In other positions, they're not there. So this is the position-related obstructive sleep apnea. And usually, it's more common in women with low BMI and a high Mallampati score. And this is important because we don't prescribe CPAP to everybody. We want to use different options which are comfortable and simpler and less expensive to the patient. So percentage of supine sleep and non-supine sleep should always be looked at in the sleep study. So from archaic to more advanced positional therapy devices, we have many devices now. Now we have, previously they used to tie a tennis ball. Vijay Kumar sir always used to tell us ki tennis ball therapy for positional sleep apnea. That's how I learned. And now we have more vibrational devices which program us to sleep to the lateral side, right? So even somebody like Kumbhakarna also can be benefited with positional therapy, but we should not neglect the positional therapy. It can be as an adjunct. Sometimes, CPAP with positional therapy will make the CPAP pressure reduce by 3 to 5 centimeters. So now the last story of a woman with difficulty sleeping. This is my favorite area. In addition to sleep disordered breathing, insomnia. So here what is happening? 30-year-old woman, difficulty falling and staying asleep, which started about 5 years back. She lost her job about 5 years back. After that, this problem got triggered off. She goes to bed by 10 p.m. but does not fall asleep. She has racing thoughts, 3 to 4 awakenings each night, final awakening at 6:30 a.m., multiple sleeping pills, multiple doctors, neurologists, psychiatrists, nothing effective. Good night sleep when on vacation. When she goes to a different place, relative's place on vacation, she is able to sleep well. Bedroom atmosphere is good, and daytime fatigue is there. She doesn't do any naps but takes more tea, coffee. And husband noticed snoring, and she's thin, nervous disposition, and grade 3 Malampati score. So this is how we just started off, sir, with our sleep logs. We are more in the developing stage, and so I just asked them. Actually, the problem is to convince the patient to religiously, meticulously fill the sleep log also is there. And now I'm convincing my patients, yes, you have to get back to me at the next visit with the sleep log. Then only I will be able to help you. Otherwise, I cannot give you the behavioral therapy for the next this thing. So you can see here, day 1, day 2, day 7. Around 10 p.m. she's going to the bedroom, almost 2.5 hours or 2 hours, she's not able to sleep. After falling asleep, she's awake again for about, she's waking up almost on average 2 to 3 times per night. Each time it is taking 1.5 hours to sleep is not there, and waking up at 6:30 a.m. So overall, though she's spending time in the bed for about 9 hours, she's sleeping only for about 5.5 hours. And her sleep efficiency is coming to around maybe 58-60%. So we did a level 1 sleep study because of snoring history. There could be a comorbid sleep apnea along with insomnia. So we just did it, but there was nothing. The HA was normal, there was no RARAS, nothing. Sleep study was normal. In fact, you can see that her sleep efficiency here is 85%. In the sleep lab, she was able to sleep well, and all the stages of sleep were good. So of all these types of insomnia, now there is nothing like primary and secondary insomnia. There is a psychophysiologic insomnia, idiopathic insomnia, which is there from childhood, paradoxical insomnia. That means the patient feels that they are not able to sleep, but actually they sleep well. Then there are other disorders. So this patient falls under a psychophysiological insomnia, wherein there are certain predisposing factors, being a woman, more anxious predisposition and all these things. The precipitating factor here is the 3P model, is the loss of job. So any acute life stresses or medical illnesses or psychiatric episodes like psychosis or something adding on precipitates the insomnia. And here you can see the perpetuating factor. That means even after the initial precipitating factor is gone, they adapt to this situation in a bad way, and they tend to spend either more time in bed or they think excessively about sleep and they have certain false beliefs. So this is a good stimulus. Bedroom is only for sleep. So bedroom is not for TV watching. Bedroom is not for worrying in bed, sleeping in bed, eating in bed, and doing other reading in bed, all other activities in bed. So many of the IT professionals, they say that they don't have any delineation. They say from 8 o'clock we spend in our bedroom only. There is no delineation between hall and bedroom. So I think there is one significant factor leading to stimulus discontrol. So what happens when there is insomnia? They can have emotional arousal, somatic arousal like sweating, palpitations, or they can have a cognitive arousal where there will be racing thoughts and patients will not be asleep. And all these things will lead to maladaptive habits where they try to spend more time in the bed because they are sleeping less, or they have unrealistic expectations about sleep. So that is what we are trying. So here I just explained about the same thing. So what is we meant by cognitive behavioral therapy, which I got very interested in, is we try to address this sort of behavioral component and cognitive component. We need to change the behaviors of the patient. We need to make the patient realize their unrealistic expectations and the fear they have about consequences of their sleep. They think that because they're not sleeping well, they might land up in serious problems. So these are the components that we address in cognitive behavioral therapy. So this is how we designed our insomnia program, sir. We labeled it as a Sleep Easy program, and we made it as a package because otherwise patients do tend to drop out. So we wanted them to complete the program, so we made it very economical, about 4 or 5 consultations, and in 2 weeks gap, they come back to us with a sleep lab. This is just has started. My first patient actually, in fact, completed the course, and her sleep efficiency was about 60% improved to 85%, and she's very happy with that. So that is what here is. So in fact, these patients have a reverse first night effect in the sleep lab. First night effect means patient doesn't sleep well in the sleep lab, then we can't get enough data. Here in these these sort of patients, psychophysiologic insomnia or paradoxical insomnia, they sleep very well in the sleep lab. This is one slide I wanted to show. I had done a survey on IT professionals in Hyderabad to look at the use of electronic gadgets 1 hour before bedtime and to see their sleep problems. 95% is the usage of electronic gadgets 1 hour before bedtime, and 56.5% had sleep problems associated with caffeinated drinks, reduced physical activity. So this was about 500 patients we did this survey. So this is what I want to say, and I'm sure you're all eagerly waiting for Dr. Suri's talk. Thank you very much.